healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Good afternoon, everyone, and thank you for joining today's episode. I really appreciate everyone climbing on board as we discuss a very important topic today. I'm your host, Stuart Newsom, and with me I have Julie Graham, who's joining me today to discuss mastering cardiology claims, CVC to clinical trials. Now, Julie is the Senior Coding Manager for the ERS Division of Infinix Healthcare and brings a wealth of knowledge regarding cardiology coding. How are you doing today, Julie?
I'm great. Thank you so much for the introduction.
Oh, you're very welcome. Very excited to have you here.
Thank you.
As the title insinuates, we are going to dive into some of the critical aspects of cardiology claims, specifically focusing on central CVC placement and the nuances of coding for cardiology procedures that require clinical trial numbers. Now, I know that's very, very specific, but believe me, it's very involved, as you can see.
Yes.
Now, the landscape, as we all know, and I've been saying this at least for all the episodes that I've been a part of, medical billing and coding, it's always evolving. It's always changing. There's always updates to coding standards, as well as any insurance policies frequently impacting how claims are processed and reimbursed. Sometimes there's also missteps in coding that can lead to denials, delays, significant financial discrepancies, and reimbursements, which none of us really want. It seems the theme throughout all of anything to do with trying to optimize your revenue, the biggest nemesis is always those denials. Now, Julie has navigated these challenges firsthand. She has many methods to not only tackle a lot of these issues, but to also educate and empower coding professionals to improve their accuracy and efficiency. So hopefully by the end of this session, our goal at least is for each of you to leave with actionable tips and a clearer understanding of how to master these complex areas of cardiology coding, ensuring that your claims are not only accepted, but reimbursed at the rate they deserve. And hopefully not just cardiology, but this could also bleed over into other specialties as well. So let's get started, Julie. The first question right out of the gate, could you highlight some of the most common coding challenges and pitfalls you've encountered with central venous catheter placements, particularly when dealing with the tunneled versus non-tunneled catheters?
Yes. So one of the most important things is understanding the documentation of the provider so that you're capturing the correct CPT code. And so there is a difference between tunneled and non-tunneled catheter placements, and there are different codes for those. So first of all, just understanding what a central venous access device is. You may see the doctor listed as CVAD or CVC or central line within the report. So understanding what that is to start with. So a CVC or central venous access device is just a thin, soft, flexible tube that is placed in a vein leading into your heart. And these are placed for long-term delivery of medication, nutrition, and fluids. And so the difference between the tunneled and the non-tunneled, so your tunneled is for your long-term and non-tunneled is short-term. It's your short-term IV catheter used for temporary venous access, and it allows for the quick delivery of medications and fluids, so it's not over a longer extended period. One important thing to note that you might see in the documentation is you think of a non-tunneled catheter as superficial. So this does not have a tract going under the skin. There's no cuff to prevent infection. And often these can be placed at the bedside. So not to say that they always are, but that's something that you can look out for. And actually a PICC line, your peripheral inserted central venous line, is the most common type of non-tunneled catheter. And so tunneled catheters actually require a surgical placement. It's a surgical procedure, so think deep. So with our non-tunneled, it's superficial. With our tunneled, it's a deep placement. These catheters are placed under the skin and are suitable for long-term use.
Nice, nice. So great explanation. I think that's definitely context plays a key part, especially when it's coding. for these
Yes.
services. So what are some of the best practices for coding different types of central venous access devices, especially considering the factors like the presence of a port or a pump, which I think you alluded
Right.
to a little bit already, but
Right.
how do these details influence the documentation and claim approval process?
Well, they affect it because, again, you'll have to read that documentation to know which code is most applicable to what the doctor is placing. But another thing we have to think about is coders and auditors alike is how these codes are based or how they're created, like their definitions when you're reading the that in CPT. So these are based on age, and that being either less than 5 years of age or over 5 years of age, whether it's tunneled or non-tunneled, whether it's with or without subcutaneous port or pump. And so those are the things that we're looking for. And then when you venture over into the PIC catheter placement, then we are also looking for, was it done with or without imaging? There are codes for a PIC placement without imaging, and then there are codes for PIC placement with imaging. And then there are codes for PIC placement with subcutaneous port. So you really have to read these codes to understand the correct code selection. So for example, our non-tunneled codes are your 36555 and 36556. And respectfully, that is the 36555, 556 is for over 5 years of age. And that's how kind of all of these codes go. You'll see with the tunneled without subcutaneous port or pump, the 36557, 36558. These are also listed as under or over age 5. So now with the port or pump, what you will see in the documentation that kind of helps you identify the difference between non-tunneled and tunneled is that it's a pocket created. There has to be a pocket created for that port or pump to be located. So when you're reading the documentation, if you see that the provider's creating a pocket for a port or a pump, that will kind of let you know what code you should be looking at. And then also you have to look at entry sites, where the catheter is being placed. So that will also let you know if you're in the right area. So for example, when you're talking about when you're talking about tunneled, so the documentation for central venous access catheters, the tip should be terminating in the subclavian, the brachiocephalic, the iliac veins, the central venous, or the SVC or the IVC or the right atrium. And that's the superior vena cava and the inferior vena cava. I totally forgot what those meant for just a second, which I'm so sorry.
No worries.
I'm going saphenous vein, cardio coder mind. And then the venous access may be either centrally inserted, either in the jugular, the subclavian, the femoral vein, the IVC, or as the catheter site. So those are things that you can look for within that documentation to ensure that you're selecting the right code.
Right, right. So documentation is so important in interpreting that documentation. And this next question is kind of elaborating on the comprehensive documentation requirements for CVAD placements. But I think the bigger picture is also the importance of documentation, of certain details, like the catheter
Right.
tip location. I think you've
Yes.
alluded on this before, but say the documentation is just not there. I mean, I know there's documentation there, and I've always said that from a clinical aspect, when a physician documents, they're assuming another clinical person is going to understand the documentation.
Yes,
And
sir.
that's the importance of the coder, is to translate that into a code. So it's very important to read that documentation from a clinical mindset so that you can then transfer it to a code. So, but what if the documentation requirements haven't been fulfilled? I mean, what can you elaborate on those requirements?
Absolutely. I mean, if you've come across this and there's no documentation of the catheter place or where the catheter tip is, then you have to bill it with a modifier 52. And
Mhm.
so that's a obviously reduced procedural service. So the documentation, that's something that coders can speak with their doctors about. One of our clients, there was a provider that was billing for these tunneled catheters, but was omitting where the catheter tip was. So I simply had to reach out to him, have a quick conversation. And he said, wow, I never knew that. Thank you for letting me know. And it was, it hit the change in his documentation was immediate.
Oh, yeah.
So, I just wanted him, it's important that they know that, because if they're ever audited, if it's not something that's being caught immediately and it's something that's, caught down the road, then he or she can stand to lose, that reimbursement. So you want to make sure that they know that the documentation requirements for that. And so, even talking about peripherally inserted. So when we're talking about peripherally inserted catheters, those are inserted via the basilic, cephalic, or saphenous vein entry site. And if you're going to use ultrasound guidance for PICC line placement, the documentation should also include evaluation of the potential puncture sites, the patency of the entry site, and that the real-time ultrasound visualization needle entry into the vein. So all of that has to be documented with that, that hard copy being kept. You don't have to necessarily say, I saved a hard copy of this, but if it's requested by the insurance, then you have to have that record available for them. So yeah, if there's no confirmation of the catheter tip, then you have to bill with modifier 52.
Wow. Yeah. So you have to have that knowledge as well. And obviously you want that documentation to avoid modifier 52.
Because
But yeah,
that's a reduction in payment. Yeah.
exactly.
You don't get the full reimbursement.
It all goes back to documentation, and I think you just can't say it enough how documentation impacts reimbursement, because and also keeping the money, because you mentioned compliance. If you're ever audited, it's one thing to get paid, it's also another thing to keep the money. So making sure that documentation is there is key, absolutely key.
Right. And it goes back to our overarching theme, which is, our foundation of any service that we provide is medical necessity. So that documentation also supports the medical necessity for what that provider is doing. And so just one last little tip before we move on to our next topic. There's also, if you look in CPT, I have the CPT professional edition for 2024. CPT has a wealth of information in there for coders, and newer, more seasoned coders know this, but if there's any newer coders out there, they may not know this. So there's also definitions. If you look on page 303 in your CPT book, it will give you definitions of what is required or expected to use the repair codes versus partial replacement versus complete replacement. So that's always great information and knowledge to have, and that you can also take back to your provider if you're seeing that that's just not being met, or there's just an opportunity for a little bit of clinical documentation improvement, CDI.
Yeah, awesome. Awesome. Yep. That CPT professional is like the Bible for coding.
Yes, it is.
It's great.
It is our Bible.
It's great. I know I have one too sitting over my shelf, believe it or not. So let's shift to clinical trial numbers. And you're sitting there thinking, what in the world is a clinical trial number? I'm sure people would know what that is, but why is including the clinical trial number in the claims for procedures like TAVR and TMVR crucial? And what typically happens when these numbers are omitted from the claims?
Well, again, going back to, documentation and establishing medical necessity and everything that's required, being compliant. And so clinical trial numbers, if they're not included on the claim, if they've been omitted, then you're going to get a delay of payment. There's going to be a denial on that claim, which again just slows down that flow of collections, and so it can affect your bottom dollar, your bottom line at the end of the month, if you've had a lot of these claims and weren't familiar with that requirement and how to bill them, and even where it goes on the claim. So the clinical trial number, these are used to identify clinical trials and are assigned by different organizations. The national clinical trial number is assigned by clinicaltrials.gov when a study has been registered. And so why these are done is the clinical trials are research studies that test the safety and effectiveness of interventions and procedures on people's health. So they're looking to see, how did this affect the patient? Were these, was there a great benefit, great outcome with maybe less invasiveness? especially when we're talking about the TAVR or the TMVR. These are transcatheters, so they're not open. So they're looking for that effectiveness and the safety of those. And so this is a direct quote, from CMS on clinical trial numbers. And it says, the principal purpose of the study is to test whether the item or service meaningfully improves health outcomes and affected beneficiaries who are represented by the enrolled subjects. So that's basically what these procedures are for, and they're identified by these clinical trial numbers. And so some cardiology procedures, I know you mentioned a couple, but a few other of cardiology procedures that are affected by clinical trial numbers, in addition to the TAVR and the TMVR, which is the transcatheter aortic valve replacement and the transcatheter mitral valve repair. Be careful, or, make note that one of them is replacement and the other one is repair. It's also for the left atrial appendage clip, which you may see listed as LAAC. Also for your leadless pacemaker, like the Mirka, I think I'm saying that right, or the ABR. Oftentimes you can find that if you're unsure if you have a procedure that's maybe relatively new, you're just not sure if it requires a CTN or not, you can look for an NCD. If the NCD will tell you if there is a CTN required. So that's something to keep in mind if you're not sure. Not necessarily the billing and coding articles, but that NCD will let you know if a CTN is required. Now, if you have a procedure that you have no idea, it requires a CTN, but you don't know what the clinical trial number is, you can go to clinicaltrial.gov, but you must know the sponsor to identify the correct CTN. For example, the TAVR is sponsored by Society of Thoracic Surgeons in collaboration with the American College of Cardiology. So you have to know who sponsors it. And then you also have to make sure and pay attention to your location, because there are clinical trials all over the country. So you don't want to choose one that's being done, in Korea or something like that, because that's probably not going to pertain to, your provider here in the States. But that's just one example of how you can find that. You can also do a quick Google search. A lot of these sponsors, like, Abbott and Medtronic, they will have billing and coding. They'll put out billing and coding PDFs or education little PowerPoints on it that will sometimes even give you the CTN. So that kind of eliminates all the confusion. If you're not, the clinical trials website there's a lot going on when you look up these clinical trial numbers. And so it kind of gets a little convoluted, I guess. It's kind of maybe hard to identify what you want. And so you can always do that. I usually, just because I have attended so many different other webinars and stuff like that, I usually get my clinical trials there. But just for like the leadless pacemaker, there are, for the TAVR, there's with this specific, the sponsor of Society of Thoracic Surgeons with the AAC, there's a specific CTN for that. Now with the leadless pacemaker, there are a few different ones. I have a Post-it note in my book because there's at least 5 or 6, something like that. You have to know the manufacturer number, which model was placed to pick the correct CTN. So it can be a little bit challenging from that perspective. But if anybody's out there and they're unsure of what clinical trial number to use, I'm happy to help. If you, shoot me an email or something like that, I'm always happy to help a fellow coder or fellow AR. We're all on one team here. So yeah, if there's any questions about that, I'm happy to help on that. And then we get to the claim. So the best, this information has to be communicated on the claim too, because if it's not, like we said previously, if any of this information is missing, the claim is going to be denied, which is going to affect reimbursement, which makes not as happy physicians. So we want to keep our physicians happy. We also want to do our due diligence for our patients. So where we place on the claim. So this is from CMS directly. And so for claims received on or after April 1st, 2008, Contractor's system shall accept the numeric 8-digit clinical trial registry number when placed on the electronic claim in 837P in loop 2300. You do not use an NC or the CTN or the NCT prefix. It's numbers only. So don't make that mistake. No CT, none of those prefixes need to be on there. It's strictly the numbers. However, if you're billing a paper claim, then yes, you would have to provide that prefix on there. And then we also want to make sure that our Q0 modifier is on there. And that's typically going to be your secondary modifier. At times it may be a primary modifier, but for the most part, it's going to be secondary because like with some of these procedures, like your TAVR, it requires a co-surgeon. And so that 62 modifier is going to have to be your primary modifier. Q0 will have to be your secondary modifier. The Q0 modifier is basically saying that this is an investigational clinical service provided in a clinical research study. You may see a Q1 modifier. You don't want to use a Q1 modifier. The Q1 modifier is for routine clinical service provided in a clinical research study that is in an approved clinical research study. So we want to stick with the Q0. That's the modifier we want. We also have to use the ICD-10 as secondary diagnosis Z00.6, which also indicates that this is part of a clinical trial. So when we're reporting on our claim, what we need to make sure we have for adjudication is number one, our CTN in the correct place, and that 837P in loop 2300. And that's going to be placed in different places within different EHR systems. Your ICD-10 Z00.6 and your modifier Q0. Omission of any of these components or required elements will result in payer denial and delay of payment, which we want to avoid.
Absolutely. Wow. And so everything you were just saying there, as I was following along, it was like you're painting a picture to the insurance company as to what is
Yes,
going on here.
absolutely.
And I know everyone's thinking, wow, it's a lot of modifiers to keep up with. There's a lot of, and you mentioned the secondary code with the Z code. This is a clinical trial, but it's so important to include all those because you want to paint that picture. It doesn't delay payment because you still may get paid because it comes back as a denial and
Right,
you appeal. Well, that's costing you more money to touch that
exactly.
claim again. But have all this done the first time, it's just going to have that one step closer to getting paid.
Right. And we want to uphold the integrity, of what we do and ensure we're being compliant with these regulatory standards.
Hmm. Absolutely. So, in talking about the regulatory standards, there's a lot of policies, and we've mentioned some policies. You talked about NCD for medical necessity. There's also LCD. There's all kind of policies concerning clinical trials. So, can you discuss how changes in insurance policies and those regulations affect coding for cardiology procedures, particularly for the CVADs and clinical trials? I guess what I'm getting at is how should coders and billers stay updated and compliant? Sounds like an obvious question with an obvious answer, but it seems to be an ongoing problem.
Yeah. You can always, for payers that offer it, like CMS, you can sign up to get an emails about any of the updates that they're making on their LCDs, NCDs. So that's always one way to stay current. Actually, for what I do every year at the beginning of the year, I go in and for some other procedures that our providers do that are highly, I can't think of my words right now, that we do often for lack
Right,
of the word
right.
I can't
Yeah. High
find.
frequency.
Yes, thank you, high frequency. I actually go and I seek out these policies or look for policies on these procedures. So for the CVAD, I would go and seek out to see if, hey, does Aetna, does Blue Cross, does UHC, does United, or does Humana, does Cigna, do these are those top 5 big payers, do they have a clinical policy on this procedure? And what does that policy require? What clinical scenarios are they covering this for? And then make sure you communicate that with your provider because they don't always know. And these policies, they're not just always simple and straight to the point. Sometimes there's 4 or 5 different clinical scenarios. And so we are not clinical. We don't have that, we're not in clinic treating patients, but that's where we need the providers to understand, so we communicate that with them so they understand what clinical scenarios apply. And that's not our job to understand the clinical situation, the clinical scenarios, but it is our job to ensure that our providers are aware of any of those rules and any of those requirements, so that they are aware of what needs to be done, or what, when they're treating a patient, does this meet what that policy says that they'll reimburse this for. You know, we have to make sure that we're up on that, and that our providers are knowledgeable. So yeah, I mean, so for the CVADs, you know, go out there and see if there's a policy on it. For, you know, CMS, it's easy depending on your MAC. A lot of the MACs, you can do an LCD search to see if there's an LCD in place for a CVAD. You can even do a search for an NCD, or you can go to MCD, which is one second here, just going to pull it up real quick. So the Medicare coverage database, if you go to the Medicare coverage database, it pulls up a search bar. You can put your CPT code in there, and you can even select all states. You can select your specific state. And once you put that code in, it's going to pull up a listing of all the MACs that have an LCD for that policy, or excuse me, for that procedure and that CPT code. So sometimes it just takes a little bit of legwork. And one other thing I would suggest is, just from an AR standpoint, somebody else taught me this, and I really admire her, and she teaches me so much, and I just appreciate her so much, is adding rules into our EHR systems, creating a rule in these EHR systems that says, hey, if I have a TAVR or a left atrial appendage clip or a leadless pacemaker, this claim cannot go out unless these required elements are on the claim. So
Right.
that's definitely something you can do to be proactive and prevent that denial, right? So, and with the CVADs, you could even probably put a rule to double check that documentation, have the coder really read that documentation to make sure that it meets it. And if it doesn't, then you can take that directly back to the doctor and say, hey, this is what we're seeing, or this is what we found. And at that point, you have the opportunity for the doctor to add an addendum. And addendums can only be added for so long. So if it's 6 months, a year down the road, you don't have that opportunity. So that's another opportunity to help you and prevent those denials and prevent that claim from going out.
Oh, absolutely. That's very helpful. And then with that, we're going to wrap things up here. I wanted to give everyone an opportunity to submit some Q&A. We do have one question here that's coming in, and this is, Julie, given your extensive experience, could you share some overarching strategies or tips to help practice administrators enhance coding accuracy and reduce the frequency of insurance denials? That can apply to just about anything, right?
I think yeah, I mean, that's a great question. And practice administrators, they wear a lot of hats. So I think that goes with regulatory audits, or setting a cadence on how often you want to do audits to catch things. And that will help you identify where there might be some leakages or some weaknesses within documentation or within the coding that may require additional coder education or additional physician documentation, and therefore also eliminating and circumventing any denials.
Nice. So we do have one other question here, and actually two coming in. Great. So I'm getting conflicting information on when Medicare is responsible versus MA plans.
I'm sorry, I don't understand the question.
And I think they're getting conflicting information on responsible versus managed care plans.
Okay, I'm just going to answer this from off the top of my head, what's coming to me, and that would be, I mean, does the patient have traditional Medicare, or do they have a managed care plan? Do they have Medicare as secondary, and who's your primary and your secondary payer? That's where my mind goes on that. Yeah. I mean, if they have like Blue Cross Blue Shield primary and then like a managed care secondary, yeah, or maybe vice versa.
Medicare Advantage. I should say managed care. I should say Medicare Advantage plans.
Well, I think one important thing to remember is that if Medicare doesn't, if their managed care is primary and maybe they have a Blue Cross secondary, if Medicare doesn't cover it, then the secondary, like Blue Cross or something's not going to cover it. Blue Cross is going to cover it. Or if Medicare covers it, then the secondary should cover it too, those crossover claims. But I'm not sure that was really the answer to your question, and I'm so sorry.
Right. I think they were looking at just Medicare specifically, and which when Medicare is responsible for it versus the Medicare Advantage plan, so to speak.
Well, yeah, I don't know. If you're talking about from like a policy like LCD, should be following Medicare guidelines unless they've
Yeah.
established their own
Medicare is
guidelines.
pretty clear. I know from my experience, Medicare is pretty clear on what is covered and also what services that are just non-covered services, no matter what.
Yeah.
So again, like Julie said, I think if you go out and look at your MAC, especially, and then also look up the LCDs, NCDs, the Medicare coverage database is also very helpful. All those resources will help alleviate what Medicare is definitively responsible for. If they're not, and the policy says they are, then you need to supply that documentation in the appeals process.
Yes.
For sure. I know it's a headache, but they just you need to call them out on it, basically.
Yes. And to my knowledge, Medicare does cover CVADs and PICs. I don't have any problem. We don't have any problem getting those paid. It's just documentation wise. We have to stay on top of the physicians sometimes.
Right. So one more question. This might be an easy one, but please, you mentioned modifier Q0. What was the other one? Is there anything else? Thanks. Yeah.
That was Q1, which Q1 is for routine clinical service provided in a clinical research study that is in an approved clinical research study. It seems very redundant. Very redundant modifier.
Well, a lot of the language in those modifiers and even in CPT codes, but they can seem so similar, but it's just one comma or semicolon or little word at the very end can make all the difference for sure.
I just wanted to bring both of those up because I didn't want there to be any confusion out there for anybody who's never heard of the Q0 or the Q1 modifier and wasn't sure which one to use for the purposes of what we were discussing today. Our focus is Q0, but I wanted to bring a definition for Q1.
Awesome. Julie, thank you again for joining us today.
Yes, thank you.
This was very insightful. I enjoyed it. And I hope everyone else enjoyed it. If you have any additional questions, you can reach out to us. And also, please be sure to go to our website, check out some of our previous webinars, and stay tuned for next week's webinar as well. Hope you join us. And thank you for coming. Thanks.
Thank you.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.